Good afternoon, ladies and gentlemen. Like it just has been told by CEO, we are concentrating on the common topics. A case of pain chest. Whether we are working as general practitioners or physicians or the cardiologist, we will keep on getting the cases of pain chest wherever we are working. And a systematic approach, an early diagnosis, and timely intervention not only benefits the patient, even the doctors also. So with that background, I take up this talk on approach in the case of pain chest. It is a wide spectrum, right from life-threatening condition to the benign conditions which can be there. And a detailed history, meticulous examination, and the basic investigation like ECG, X-ray, and a bedside troponin can help us in clinching the diagnosis. I'm not going to make it as a lecture. In 2 or 3 minutes, we are going to have an interactive session on the pain chest. You will be sharing your experience, I'll share my experience. But just prior to that, I want to just enumerate the cases which are there, the life-threatening pain chest and which are the benign pain chest. So let's go one by one. Acute coronary syndrome. I need not to express to the august guardians how they present with the pain chest, which is radiate to the back or the shoulder associated with diaphoresis, and simple ECG and troponin T can help us in diagnosis. Aortic dissection. Pain which is present over the chest can go to the back. Pulse can be different in the left and right. BP can be different. In that situation, just a plain, simple X-ray, if echo facility is available, that can also help us in clinching the diagnosis. A patient with the circumstantial evidence undergone any kind of a surgery, lower limb, or DVT, bedridden, gets sudden onset pain, chest, and breathlessness. It takes us towards the diagnosis of pulmonary embolism. You need not to run around, just do the ECG, and you can clinch the diagnosis with the ECG, and if possible, echocardiography will help. Pneumothorax, again, presenting with a pain chest, sudden onset breathlessness, a simple X-ray and the ECG can clinch the diagnosis, and a single needle over there in the second intercostal space can relieve the pneumothorax also, if the ICDs facilities are not available. Cardiac tamponade, again, the triad, the raised JVP, hypotension, and the feeble heart sounds. You can make a diagnosis sitting over there wherever you are. Mediastinal esophageal rupture, again the triad of pain chest with vomiting. Associated septicemia might be there, and you can make a diagnosis of esophageal rupture. Now look at the benign chest pain. Musculoskeletal, young patient without any risk factors coming with a pain chest, local tenderness present, costochondritis. Patient has got dyspeptic symptom after meals or empty stomach, esophagitis. Bronchitis, patient coming with fever, dry cough, you can have features of bronchitis, cough, pleuritis. Herpes zoster, with the past history herpes zoster is there, you can have post-herpetic neuralgia. Even the patient who are going to herpes zoster can have pain and distributed with dermatomes in intercostal places, you can make out from that. Sickle cell anemia is another one which can cause a pain chest. And breast-related problems in the female, particularly young female, they're all benign condition. These patients can be seen in OPD and can be disposed of. One need not to admit these cases. But there's another group, which is neither a life-threatening nor the benign. But these patients, they require hospitalization and further evaluation and the management. Pericarditis, myocarditis, aortic stenosis, hypertrophic cardiomyopathy, mitral valve prolapse, RSOV. These are all conditions which require hospitalization. So my aim was to put in a different group, life-threatening versus benign, and the patient, those who might require investigation and further evaluation. This is just to give you an overview and the cause of pain chest. Now we come one by one. 65 years old executive, known cause of hypertension, diabetes mellitus, presented with prolonged pain chest of more than 30 minutes duration. There were associated diaphoresis was present. The pain was radiated towards the left shoulder, back, associated with mark sweating. There was difficulty in breathing. Feeling of impending doom is there. Now it is going to be interactive section. I think the diagnosis is clear. Anybody? Anji. So I think it's very clear. So to support this, we go on the examination, pulse is 55, the BP 100/70, basal caps upper. Trop T was negative. Now the thing is, the patient was brought within 1 hour of his pain chest, so Trop T was not positive, and this was the electrocardiogram. ST elevation in second, third AVF, suggestive of inferior wall myocardial infarction. Simple, straightforward case, can be diagnosed in a clinic wherever we are working or in OPD. So after this, diagnosis is clear, treatment part is concerned, of course thrombolysis oblique primary angioplasty, you have to send the patient for that, but the supportive treatment which can be started at your clinic is antiplatelet, statins, nitrates, morphine, beta blockers if there are no contraindications. Second case, 67 years old male, known case of hypertension, diabetes mellitus, who had already undergone angioplasty to left circumflex artery earlier. Now this patient presents with history of rectoesternal pain chest in the morning while lifting a box. He is brought to the hospital around 2 o'clock after 6 to 8 hours, and after coming to the hospital, the Trop T is found to be positive. Now this is the electrocardiogram. You have recorded ECG in your clinic, you have recorded clinic in your OPD. There is no ST elevation, but there is a definite ST depression which is present over the Trop T positive. So diagnosis becomes again clear. Anybody who can just participate into this? So it becomes a ACS, a non-ST elevation MI. He also requires the same kind of a treatment which is there besides the antiplatelet, nitrate, statins, beta blocker. Angiography is must. And if the facilities are available, please get the echo done before sending the patient for angiography. 30 years old male had open reduction, internal fixation of the ankle fracture about 2 weeks ago. He is lying with this POP on. Now presents with a history of sudden onset chest pain and breathlessness. He is coming to you, or you are going to see him in his house. ECG machine is with us. Next is what we do is just record the ECG. And look at that. The ECG itself is speaking of the diagnosis. The rate is increased, there is sinus tachycardia. There is evidence of T inversion in V1 to V3 field leads. There is right axis deviation. There is S1 T3 Q3 pattern, which is although found 10 to 20% of the cases, but is positive in this case. So the diagnosis is clear. A case of pulmonary thromboembolism, and this patient, confirmation after the echocardiography, will be benefited with the thrombolysis therapy. Those are circumstantial evidence plus the ECG, and of course supported by echocardiography. The diagnosis of pulmonary thrombolism becomes easier, and straight away we can subject this patient for the intervention, that is thrombolysis. So pulmonary embolism, sudden onset dyspnea, tachypnea, tachycardia, hypotension, hypoxia. If the signs of DVT are present, that further supports the diagnosis. Like I told you, ECG is supportive, X-ray might not help, but echocardiography helps. D-dimer facility is not available outside OPD, but definitely in the hospital we can do the D-dimer for further confirmation of the diagnosis. Management, thrombolysis. If the patient has got hypotension, hypoxia, RV dysfunction, don't delay it. It's a life-saving. If these things are not there, patient is not hemodynamically compromised, the patient is not having hypoxia, patient RV dysfunction, one can think of heparin. Otherwise, the thrombolysis. Lot many patients have been saved in this very hospital also by prompt diagnosis and early thrombolysis. Another example. A 35 years old male with a feature of marfanoid features presented with sudden onset, ripping pain radiating towards back associated with syncope. And include young chap.
How did
aortic dissection. So that's what I'm telling, means one need not to go into sophisticated investigation, even the examination before the diagnosis is made. 35 years, marfanoid features are present, ripping pain is there, going towards the back, syncope is present. So it takes us a clue that this patient is not having a kind of a ACS, a pain which is because of some other reason, and this is important not only for the diagnosis and management. The aortic dissection is important for diagnosis. We should not thrombolize these patients, because when the aortic dissection is present and sometimes there are changes of inferior wall MI, by mistake we thrombolize the patient, it will go to catastrophe. So that's a very important for diagnosis and management, as well as to see to it that erroneously the patient is not being thrombolized. Asymmetrical pulse, difference in BP in the right and left arm may be there if associated brachiocephalic is involved, and murmur of aortic regurgitation. Just one, we have to put a stent and see for this whether the patient has got aortic dissection or the CAD. We come to robotic ECG. You might get the evidence of inferior wall MI if it is type A dissection is present. X-ray chest is facilities are available everywhere. You can just see the mediastinal winding, and there's something known as knuckle sign. If there's a calcification, you can see the gap around 1 centimeter which is present on this border. So it's very simple. The neurological symptoms usually are present the syncope, and they can be associated pericardial effusion or pleural effusion also, if it gets ruptured in the pericardium or the pleura which is present over there. Echocardiography, of course, is going to confirm the diagnosis. Management part is concerned if it is a type A dissection, the early surgical intervention where the severe AR and all that is present. If it is type B, which is only involving the dissecting aorta, it can be managed medically if the large arteries are not involved. So surgical, medical, main hysterectomy. Now here's a very important thing. When we get a case of dissection, we try and keep the heart rate and the BP under control, so there's a DP, DT is reduced, the load on the heart is not there. Mean arterial pressure is 75, the systolic arterial pressure 100 to 120. We try and keep the heart rate of 60. Beta blockers remains the mainstay of therapy. Sometimes to reduce the BP, we might use nitroprusside, but nitroprusside should not be used in isolation. It can cause tachycardia. So beta blocker has to begin along with that. So again, patient management starts from the periphery wherever we are, and subsequently brought to the hospital, and depending on the type of lesion, the subsequently patient can be subjected for early surgery. And the 24 years old male presented with history of chest pain of 3 days duration. It was preceded by history of upper respiratory tract infection. It was progressively getting worse. It was increasing with the inspiration on lying down. He was feeling better in sitting up and leaning forward position. Hanji? You don't require an investigation for this kind of presentation. That's why I said detailed history and meticulous clinical examination, putting a stat of the patient can give a diagnosis. So it's a very simple, this thing is a pericarditis type of picture is there. History itself is suggestive, and you can see the ECG which are present over the ST elevation, concave ST elevation which are present anterior lead, inferior leads, and all over along with tachycardia. So you can make a diagnosis, and management part is not much of the difficult part. I'm not going to that detail. Now, acute pericarditis to diagnose, at least 2 criteria of 4 should be present. Typical chest pain like it was there in this case. Pericardial friction rub, if it is present, it further confirms the diagnosis. ECG changes, wide dispersed ST segment elevation with the concavity upward, and new or worsening pericardial effusion might also be there. So this is another case which we can diagnose sitting at the periphery wherever we are with simple investigations of ECG. 18 years old healthy male was lifting weights when he had sudden onset chest pain associated with shortness of breath. Heart rate has gone to 120, respiratory had gone to 34, BP had come down to 70, saturation is 88. Just putting a stent over the chest of the patient, air entry was diminished, and there was a resonance, a percussion node was present, there was diminished VFVR. So spontaneous pneumothorax and tension pneumothorax. It itself gives a diagnosis. Again, that's what I'm just telling. To start off, I started with a little going in detail of the history. and putting a stethoscope, half the battle is won. And then subsequently one odd investigation, the facility which is available with us, maybe ECG, maybe X-ray, or maybe troponin, whatever is there, we can still cleanse the diagnosis at 80 to 90% of the cases. X-ray. You can see the air in the pleura, tracheal shift that side, and definitely life-saving, putting a needle in the second intercostal space can be life-saving, otherwise ICD, intercostal drainage can be done. Tension pneumothorax, I'm not going to detail, I already told you. ECG sometimes can have a low voltage ECG because of the air which is present with the heart and the chest wall. X-ray is of course diagnostic. If the tension pneumothorax is, you can get a distended neck vein also along with the tracheal deviation. So ladies and gentlemen, chest pain is a very common complaint, but has got a broad differential diagnosis. Diagnosis can be cleansed just by history, clinical examination, and ECG, X-ray, the facility which are available all over the periphery and the clinic. Always we should rule out the life-threatening causes of chest pain, so that the patient can be directed or to be sent to the nearest hospital where further management can be done. That's why it's a win-win situation for everyone. Win-win situation for the patient. He gets timely treatment. Win-win situation for the doctor who is treating, and win-win situation for the institution where it's coming. So if we are little alert and we can make the diagnosis based on clinical presentation, ECG, X-ray, further evaluation, investigation can be done in the nearest hospitals. It is important to remember that troponin may only be increased after 3 to 4 hours of the MI. That's why in our first case, where the patient had pain and came to the hospital within an hour, the troponin was not positive. But simultaneously, we have to be careful on a raised level of troponin does not always mean presence of ACS, because it can be raised or it can be high, found to be positive in a cases where the myocardium involved because of any reason. It's beside the ACS, can be the myocarditis, any intervention has been done, EPRFA has been done, or particularly the patient who has got a renal involvement, a renal failure as well as sepsis. So even pulmonary embolism also it can be positive. So we should not take troponin positive in isolation for the diagnosis of ACS. Out of the 3 factors, classical pain chest, ECG and troponin or raised enzymes, 2 has to be positive to diagnose a case of MI. So that's it, pulmonary embolism, post DC shock, sometimes DC shock, after DC shock also we get the raised enzyme. Renal failure, myocarditis, they are the common features. So this is an important thing which is we have to keep in mind while considering the top 3. So this is the way we can diagnose just by history, clinical examination, ECG, X-ray, common cases of pain chest which are life-threatening or benign. Life-threatening can be directed to the hospital as fast as possible. Those who are benign can be sent home from the OPD and without wasting much of that time. One point of advice, you can call it, or one point which I can tell out of my experience, any person who is coming to the pain chest to the hospital, for them it's a heart attack until that's proved otherwise. So we have to be very, very careful in communicating to the patient, the attendants, that this is not a heart attack or this is a heart attack. Electrocardiogram is must to convince them that there is no cardiac problem, your problem is benign. In case the heart attack is there a real problem, then of course he has to be hospitalized, he has to be accordingly told. Number of times it has happened, the patient has come, we have diagnosed the patient of costochondritis and myalgia and all that. Patient says, नहीं साहब ये तो हो ही नहीं सकता, patient को इतना दर्द है, heart attack के लिए आपने कुछ किया तो है ही नहीं. So that part has to be taken into consideration. All the patients who are coming to you in your clinic or coming to the hospital or in OPD, one electrocardiogram, even the condition may be benign, because sometimes these hidden things can come out, and second thing is the patient satisfaction are 100% surety. There's a very simple, straightforward investigation which helps us. So thank you very much. If you have any questions.